We're going to be doing a video for a comprehensive total shoulder, specifically when you're on call on the weekends, and most likely someone at Kaiser Oakland is going to have a proximal humerus fracture. And so we're going to learn how to do both the mini stems, the fracture stems, and the reverse for the comprehensive. So we're going to start with our reamers. If you notice, we've got a T-handle, and we're always going to load up the very first reamer, which is the sharpest and the pointiest. The very first one has just the 4 standard. You're always going to start with that one. Typically with Dr. Gill and Dr. Hatch, they like to jump by 2s. So the next one you're going to grab after that is going to be the 3rd one up. And we always typically go by the mini stems. So we're referring to the bottom MI numbers. So it'll typically go 6 mini, 8 mini, and then depending on if it's male or female, I usually have the mask. If it's female, we'll go up by 1s. If it's male, we typically go up by 2 again and then by 1s. So we would go to 9 for a female and typically 11 for a male and go by 1s from there. We're going to set up the cut guide, which you set up prior to the case starting with the scrub tech. This is probably going to be the most complicated part of our setup, but it's pretty easy once you get it down. So I have the scrub tech have the rod facing towards them so that the numbers are oriented so you can read them. And then based on if we're doing a right or a left shoulder, we want to have that word left or right facing towards them. So the bar is facing towards the tech, and then let's say we're doing a left shoulder. The word left is being read by the scrub tech, and we have this screw, which is captured, unscrewed, and you just slide it so that that screw goes in the gutter of that rod that's pointing towards them. So that goes on, have them just lock it in the middle. And then most of our doctors like 30 degrees version. So since we're doing a left shoulder, we're gonna thread this into 30L. And then another little side note, this big knob gets in the way if it's on the same side as the version rod. So you always very carefully have the scrub tech unscrew it and move it to the other side of the gutter. Makes it easier for the surgeons. But it does fall out, and I have seen it bounce off of the OR table. So this is our cut guide. So the doctor's gonna ream, leave the reamer in the humeral canal that they like, and then they're gonna take the T-handle off, and they're going to set the cut guide where they want it. They're gonna tighten it, and then we have opened, or there might be in the tray, short Simon pin. It comes in a 2-pack. Our surgeons typically, well, at least the Kaiser surgeons usually only use 1. Put this just on a wire driver. Don't deal with that pin driver in there, and they will put this in where they want it, and then our surgeons typically leave everything in, use their sagittal saw. It's the same saw as total knee. And then after that, they're going to take the pin driver, take the pin out. They're going to take the T-handle back. They're going to take the reamer out. They're going to take everything out. And then they're going to use the saw again to complete their cut. So let's say we reamed to a 12 mini. So now that the humeral head's been cut off, then we're going to broach. So going again with the left side 30 degrees. On here, we've got our version. We're gonna set it to 30L. We have 2 different kinds of broach handles. In the tray number 2, which is the broach tray, comes the collared broach handle. You'll notice the dark handle matches the dark broaches. In our retractor tray, you should have a collarless broach handle, which I'm going to show you the difference. So there's a collar at the tip. This one does not have a collar. We always broach with the collared handle, and we always go 3 below our last ream. So we ream to a 12. We're going to grab the 10, 11, and 12. And these are mini broaches. Mini is 83 millimeters in length. So you're going to pull the trigger, and you usually hear that audible click, and I always have the tech pull on it because sometimes it doesn't click all the way, and then you hand this over with the mallet for the doctor. So they'll broach, and then they'll go up to the 11, see, it gets a little sticky, and then to the 12. Typically they'll leave the 12 in, And then sometimes if they want to sink the brooch and they want to use the Calcar planer, that's when they'll ask for the collarless brooch handle. That allows them to sink it further down the humeral canal. And then we don't have the Calcar planer set up, but we'll show you in a later time. So they leave the brooch in, and now they're going to move to our glenoid.
Do you want to talk about fracture stem at that point?
Yeah, and let's do a fracture stem. So remember how we had two different numbers. So with our fracture stem, since the fracture stem is the same length as our standard length stems, they're 122 millimeters in length. You're going to actually reference on these reamers the standard number when we're reaming. So before, when we're doing the mini stems, so this is obviously something you're going to get clarification on prior to the case if the surgeon's planning on using the mini stems or the fracture stems. So when we're reaming, then we're going to reference those standard numbers. And just so that you know, our fracture stems only come in evens. So we've got 4, 6, 8, 10, 12, and 14. And something tricky with Legacy Biomet is it's not line to line like our Zimmer LDFX fracture stems. So let's say we ream, let's go back to that magic number of 12. But now we're referencing the 12 standard. So we ream to a 12 standard. You still have to take into consideration a 2 to 3 millimeter cement mantle. So even though we ream to a 12, if the doctor decided he wanted to maybe do a press fit or a very, very, very light coat of cement, he can trial with this, and this is what his actual 12 fracture stem will feel like. But if he wants to put a lot more cement, it's suggested that they downsize down to the 10. So that's something that you always have to keep in mind. You are able to press fit because there is PPS porous coating proximally on the fracture stem, but it's obviously up to the surgeon's discretion on how much cement he wants to use and how much of cement mantle. So that's something you need to take into consideration. And something different about the fracture system is this handle, you still have the version, so we're gonna go back to our left side. We're still gonna go to 30, but this is an older system, and so with the newer system, we threaded in our version rods. This one's kind of a funky angle, and it doesn't even really click in very well, and we typically only have one version rod, so, and it's the same for the brooches as well as for the fracture stem implant. So just have the tech use caution. You know, it kind of goes in at a weird angle and it kind of clicks in, but I've seen it drop to the floor. But same concept, you know, let's say we end up sticking with that 12, pull the trigger, and you let it click in and make sure that they tug at it. So that would be the only difference. You're referencing the standard length numbers on the reamers, and you only have the even-sized brooches and implants for the fracture stem. All right, so we've decided we've left whatever brooch we want in. Now we're gonna move over to the reverse. And so there's some disposables that you're gonna open prior to getting to the glenoid aspect of your reverse. So we're always 100% of the time going to open the reverse shoulder Steinman pin threaded tip, which is this guy. And it has numbers on here so that there's a gauge as to which central screw we're going to use. Prior to getting to this point, we're also going to open the 2.7 peripheral screw drill bit, which is this guy. And depending on the surgeon, this is not 100% of the time used. So this is something that you want to clarify. It's the 3.2 central screw drill bit. Sometimes the hole that is created from this diamond pin is enough for the surgeons to use in preparation for their central screw. So we're gonna set up our techs, obviously, before the case. And we're gonna be using this mini base plate because, again, 98% of the time our surgeons are using the 25 millimeter mini base plates. And we're gonna use some instrumentation from this reverse tray number 7, which comes in the big black reverse case. I'm gonna grab the mini base plates. Here we go. So we're gonna grab this silver handle, and this is the sizer so that when the doctor knows he wants to use the mini base plate. So with the opening face up like a U shape, we are doing the left shoulder again. When there's 2 holes, I typically recommend the inferior of the 2 holes. A lot of the times it goes with surgeon preference. But this is our guide. So the doctor is going to use this as his sizer and his guide. There is a 10-degree inferior tilt built in. And so then on the wire driver, we have put that reverse Steinman pin, and the doctor's going to fire that in and then leave that pin in. So this is in the patient's glenoid right now. And then we're going to move right to the reamer. Everything that connects to power connects to a modified. So you're going to connect this to your modified Hudson, put it on ream. The doctor might switch it to drill. And there's no stop on this reamer. So when you're reaming, you just kind of, if the doctor isn't familiar with the system, but our Kaiser doctors are all familiar, but if they're not, there's no stop. And then most of our surgeons do not trial, but if they want to trial to make sure that that mini base plate's going to fit in properly, they're just going to slide this right over that pin, because everything is cannulated and everything goes over the Steinman pin that's still in that patient. So once we have reamed and the doctor's happy with that, we're going to show him and open the mini base plate. So again, it's a 25mm mini base plate, and something to keep in mind, there's actually 2 implants inside this box. You're gonna have the mini base plate as well as the taper adapter for the glenosphere that we're gonna use a little bit later. That taper adapter is specific to fitting inside the mini base plate. There's also 2 pink lollipops that are little, they're really mouth swabs that clean the adapters. Have the tech save those as well. And I also notify the tech, hey, when you're opening this implant, there's 2 implants and there's 2 lollipops. We're gonna save 1 implant for later, and we're gonna use the porous coated implant for now. This shiny gold handle from our tray is going to be the inserter for that mini base plate that we just opened. I tell the tech to put flat side of the mini base plate to the flat side of this, and there's no lock. There's a little rubber ring that kind of suctions it in. There's no clicking mechanism. You just want to make sure the tech pushes it fully down. And then when the doctor's ready for it, they're just gonna slide this impactor over the Steinman pin, and they're going to mallet it in. They're gonna take out their gold impactor handle, and then they're gonna use the wire driver to remove the Steinman pin. Like I mentioned, more often than not, that hole that's been created by this is enough to prep for our central screw. You're gonna wanna use the gold tipped depth gauge, and 100% of the time I always have the tech check, because the insides can get mixed up with a different depth gauge. You want to make sure that the range goes to 50. Something you want to check prior to the case. If for whatever reason it only goes to 45, you're going to have to check another depth gauge in one of your other trays, because the central screw range is 20 to 50. So if the doctor didn't already read off of when he was drilling earlier, then at this point he's going to measure his central screw. We're going to open it, and everything of all of our screws, central and peripheral, they're all 3/5. So we have different, anything with a gold stripe is a 3/5, and then this long one on the side. Some of these are getting kind of stripped and worn, so I at least make the tech aware that you can use any 3, and I just have them choose the least stripped 3/5 hex driver. So then we'll open the central screw that they want, and they'll screw it in. Something also to keep in mind, some surgeons, they know about this. This was, if we decided to drill for that central screw instead of just using the hole that was created by our Steinman pin, this is your drill guide for that 3/2 central screw. This also doubles, once that central screw is tightened in, the surgeon can put this over the screw to make sure that it's fully seated. If it's wobbling, then he knows that he still has to screw that screw down. Or he might have to take that screw out and re-drill it and prepare for the central screw to get fully seated. There is a surgeon who does like this as a drill guide, which we're getting to our peripheral screws. We have 2 options, really. Come on, little guy. There we go. Maybe. There it goes. Okay, so also in this tray, you would put this and this, but again, most of our surgeons, these, in preparing for our peripheral screws, there's 4 holes for our peripheral screws. We've got our fixed locking guide, and this is our non-locking variable guide. Both of these threads thread into the mini base plate that's been impacted into the patient, and more often than not, fixed locking screws are the most common. And we're gonna use that 2/7 peripheral screw drill bit And again, there's measuring off of this, so the doctors can kind of look and see that way. Or we're changing up a lot of our depth gauges. Some of these sets will have this universal black depth gauge, which actually could have been used in lieu of this gold one. The black one you can use for both central and peripheral. But there might also be this is not the correct one, but there might also be a gray depth gauge that goes only to 45, and it needs that thinner gray plastic tip. Not this one. This is for the central screw for a standard base plate. So in this case, we're using this black universal one. So then our peripheral screws go from 15 to 45. And you have either the fixed locking, which you used this guide for, or this does the same exact thing. It's just a little bit bigger, and some surgeons prefer it. So then it drills through here, but make sure to be careful that this part doesn't slip out. And they can also screw the screw in through this, which is a preference. But with this one, they unthread this, and then same 3/5 screwdriver. We use it for all of our peripheral screws.
Do you want to show this difference of screws real quick?
Yes, and talking about screws. So,
First screw is central.
So that first one we did is a 6/5 central screw, and in your implant box, you're only going to have one of each, ranging from 2/0 to 5/0 in increments of 5.
Mm-hmm.
Then when we get to our peripheral screws, you have non-locking and fixed locking.
Non-locking, fixed.
So they are 4/7/5 screws, and you're only going to get 2 of the non-locking in your implant bin, and you're going to have 3 of all the fixed locking. Fixed locking is most common, which is why we have 3 of those as opposed to 2 of the non-locking. And they go from 15 to 45 in increments of 5. The fixed locking screws will be blue, and your non-locking screws will be yellow. All right, so all of our screws are in, and now we're going to go back to that implant that came with your mini base plate. We're going to be using that taper adapter now. So more often, we have 2 different size glenospheres. The most common are the 36 diametered glenospheres. So you have 3 different sizes. You've got standard, +3, and +6. If the doctor wants to lateralize, then they'll be using the +3 or the +6, but most commonly, we are using the 36 standard glenosphere. Now, with a 36 standard glenosphere, the dialed in offset is only B as in boy, which is 1.5, to D as in dog, which is 3.5. If we were to use the +3 or the +6, you're going to have A as in apple, which is 0.5, to D as in dog, or to E as in elephant as your range, which goes up to 4.5 millimeters of offset that you can dial in. Again, most commonly it's minimal offset, which with the 36 standard would be B as in boy. So you put that in with the opening faced up. It's the actual implant that we're using the trial in this case. And then that taper adapter that came with your mini base plate, there's an etched line. You put that flat part in, and you line the etched line up with B as in boy or whatever offset the surgeon requests. This is your taper impactor. So you put that over the little stub of the adapter. Give it at least 3 big whacks, I tell this rep tech. So now it's all set into place, and Dr. Hatch and Gill typically just use their hands to insert the glenosphere into the base plate. Those pink lollipops that also came with that mini base plate that we saved, you want to take that plastic off, and they might use that to clean the junction before putting in the glenosphere. Some surgeons will like this. This is probably the most user-friendly inserter that we have for the glenosphere. And when that's the case, they can use this block to figure out where their offset is, where it goes maximally. They'll sometimes take a marking pen and mark it, but then you want to unscrew this guy, and then you slide it in. So much easier seeing the surgeon do it from the side. You lock it in, make sure it's in place, and then they can, again, you've got the adapter in there, but then they can kind of initiate the impaction, and then once it's kind of in place, they can slowly, very carefully take that out, slide it off, and then you have your secondary glenosphere impactor. Now, obviously, make sure sometimes these tips get mixed up because all the impactors look the same, but make sure that it fits over the curve of the glenosphere. and give another couple big whacks.
Yep.
So now your glenosphere is into your base plate. We're going to return back down to your broaches. Actually, before that, we're going to trial. So everything's color coded. If we used a 36 glenosphere, then these are the trials for the bearing for the 36. If a surgeon decided to go bigger, because we do have the 41 glenospheres, then we'd be using the blue trials for the 41 glenospheres. But again, most often we're using the 36, and more often than not, the surgeons are wanting the thinnest option. So these trials actually represent two separate implants that we're going to put together at the end of the case. So lots of different numbers, and we'll go over everything. So we have humoral trays. So the tray part is the bottom part. It's the metal, and the diameter of all of our trays are all 44. And we have 3 different thicknesses, which we'll bring over. Okay, so these are our tray implants. So you'll see that we have the diameter of 44. And this is the thinnest, which is the standard thickness. And then when you go down, you've got the 44 plus 5. And then you also have the 44 plus 10. And these trials represent the tray on the bottom, which is the 44 diameter, and also the poly bearing on the top that fits the 36 glenosphere that we put in earlier. So these, if you want to look, this is back to where our glenosphere was. We had the 36 glenosphere. So now you see we've got, it has that 44 because it matches up with the 44 diameter from our tray. And this is for the curvature of the 36 glenosphere over here. So now we have the 3 different thicknesses for the poly bearings. We've got the standard thickness, we have the standard plus 3 thickness, and the very bottom, it's the plus 3 retentive, which I also like to call deep dish. It's just got a deeper dish for if you've got like instability issues and you need to house that in a little bit easier. That's typically when the surgeon's going to use that one. So this trial is going to be your most commonly used trial that represents these two. It's your standard thickness tray on the bottom, and you've got your standard thickness poly.
Most common used.
Yes, right there.
Glenosphere, ring, bearing. Cool.
And so doctor will trial this on top of whatever broach we have, and sometimes they enjoy using this black skid, so I always have this available for them. And then once they decide that this is the thickness that they want, and let's say they wanted to go a little bit thicker, it should be organized in the progression as the different thickness combinations, because everything can combine in different directions. So the next one is going to still be the standard thickness tray, and then we go up to a plus 3 on the poly bearing. Let's say they wanted to go thicker than that. Instead of going thicker on the poly, we can't go thicker on the poly to the deep dish, but then from there, we go back to that standard thickness poly, and then we just go up to plus 5 from the plus 3. So there's different combos. You can get yourself familiarized with all of them, but like I said, most common standard. And now you're gonna open the separate tray and the separate bearing, and oftentimes, this is tricky, we are improving this shortly, use this gray block. You can put the little stub of the humoral tray in here. There's a locking ring inside. There's this tool that is sometimes not the most user-friendly, this little wing tool. There's a point at the tip, which you can use to kind of, once you find the opening of the ring, you can click it down and help spread the ring open. Then you line up the tabs and you line up the etched lines to make sure that the poly fits in place. And you can leave the wing there, usually like this, and then put the poly over, and then you use the correct impactor, which is the bulbous one that curves out, and then you can use that, and usually it's a 2-hand, 2-person job where Dr. Gill likes to be very involved, and he'll come in and he'll have the tech whack it a couple times. And you always want to make sure that they're all fully seated and there's no gaps between the tray and the bearing. So you have that together. You've confirmed at this point whether we're going fracture stem. We've cemented in the fracture stem. And usually if you're cementing, that's when you're trialing and making sure you have everything cohesive. And then you obviously open your stem implant. Keep in mind, your stem implant, if we are using the mini stems, is going to be silver. So the silver implant matches the silver implant inserter. Same concept, same idea. You pull the trigger and you click it into place. And you'll notice you can't use this, they don't work. So there's a reason. Everything's all color coded, everything matches is specifically just for the implant. So you're gonna typically use that collarless brooch handle to remove the brooch that's still in the humerus, and then we get everything ready and prepare for opening the stem implant, putting in the stem, and then we put together the tray and the bearing, and then you use this impactor to impact this on top of your stem implant, and then the surgeon will probably use this again to help reduce the glenosphere into the bearing, and that is it. So if you've used every implant, you have 10 implants on your list, and that's with 4 peripheral screws and a central screw. And then depending on how many disposables, if you open the short Steinman pin and all 3 of the long disposables, then you'll have 4 disposables. And retractors, again, 100% of the time, all the surgeons always love these bank heart retractors, or they're glenoid retractors, or they'll call them Batman and Robin, because Batman's the bigger one, Robin's the thinner one. Every once in a while, I'll see a surgeon liking the Dara. They're not typically fans of our Fukudas, but sometimes there's hospital Fukudas that are a little bit thinner and less bulky that they like. And every once in a while, this Playboy bunny-eared retractor is helpful and useful. Chandlers they like, as well as Holmans and Army Navies, but these are in our set.
Mention resetting trays in the OR.
Oh, especially at Kaiser Oakland. They're notorious for losing things. So if the tech themselves doesn't want to reset, I wait until the case is at a point where they can push off their instrument trays, and I reset everything dirty in the OR, because that alleviates us potentially losing things down in sterile processing. And there's pictures and labels, so it should make it more or less user-friendly. And that is everything. Sorry it was so long.
Well done.